Thank you so much for being here. Just remember that we are recording, and today's presentation will be added to the PFCC Partners YouTube channel. Live transcript is available as well. So this is what PFCC Partners is all about. We catalyze system improvements by centering the human experience of health, and we absolutely recognize the critical role of community engagement that it must play for every effort at delivering health equity. So we know that healthcare is an extremely complex system. And here at PFCC Partners, we believe that a system that centers care and the care process on the person has the potential to reduce the complexity as well as advance a culturally humble, equitable healthcare system. And one of the ways, excuse me, that we do this, in knowing that there's the need for the space for patients, family caregivers, and community voices within this complex system. And with that, we have the PFA network that helps to fill that space. It's a community made by patients and family advisors for patients and family advisors, using their lived experiences to influence healthcare improvement. If you're not already connected with the PFA network, we invite you to join us. There are several different ways that you can get not only informed, but involved. We have different engagement opportunities that are posted throughout the year, being able to connect our members to various projects that will transform healthcare. We have a community where you're able to join various forums, not only getting information, but sharing information as well, and creating dialogue and discussions, as well as our skills development, where we facilitate learning so that you and or your patient and family partners can become impactful and effective partners for change. So I kind of threw that. I think my colleagues, either Lindsay or Laura, will drop in the chat the link for the PFA network. And without further ado, I want to introduce and turn it over to our presenter today, who will be talking about racial equity in healthcare, the progress report, Mr. Adam Colrus.
Awesome. Thank you so much, Naomi, and welcome everyone. I'll be sharing my screen as well in just a second, but I love the quote start, Naomi. I'm going to have to steal that. Mine would be, I did the Peace Corps, and there's a quote that I've always remembered that they threw at us day one, and it was the Margaret Mead quote, and it said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, that is the only thing that ever has." And so that one was like, has always stuck with me, but I love seeing all these quotes in the chat here too. So as Naomi said, actually going to do a couple things today. Want to definitely tee you all up to some racial equity work that we're doing across the country. It's sponsored by the Commonwealth Fund. So this is stuff that's public access, free for organizations to use. I'd like to tee that up to you, give you a sense of how it might add value to your organization. And then I'm hoping to use the second half of our time together to engage in a little thought discussion and some empathy mapping, and to get some perspectives from around this room and to upskill each person on this call with a little human-centered design visual canvases. So as Naomi said, my name is Adam Colrus. I'm with a company called DoTank. We're a human-centered design firm. And I joined this company about a year ago. But prior to that, I was with the Illinois Health and Hospital Association for over 10 years. And there I was the AVP of Quality, Safety, and Health Policy, and had the privilege of working with a couple colleagues, and I think one of my colleagues is on the line right now, in co-facilitating our Patient Family Advisory Council in Illinois. So had the delight of us trying to, my background is quality improvement, patient safety, and we really were meaningfully trying to bridge that chasm between quality and safety, and truly trying to engage the patient voice and get more empathy into that process as clinicians on the back end. We're designing processes and going about ways to improve care. So that's a little bit of my background, and just really thrilled to have some time with y'all on a Friday afternoon to share. So I'll go ahead without further ado on my end and share my screen. And the first part of this will be a little bit didactic and storytelling, and we'll open it up for some questions here, and then we'll get into some fun stuff and expose you to a couple tools that we'll all engage in. But the first thing I do want to talk about is this Racial Equity in Healthcare Progress Report. So this is an assessment that has been created for healthcare organizations across the continuum, hospitals, FQHCs. We've had community-based organizations. We've actually had payers, departments of public health, a whole swath of different demographics across the continuum have taken this progress report assessment. And the aim of this assessment is to help organizations identify ways that they can bring about more equitable care. And so this was a project that when I was with the Illinois Health and Hospital Association, we kind of started this in partnership with the groups that you see below there, the University of Chicago Medicine, Rush University Medical Center. And it was a process we started back in 2020. And so I'll tee this up and talk a little bit about how it went from an Illinois kind of grown assessment into something that we're testing actually across the world now. And with the keen kind of layer on this that I'm so excited. It's really still in beta form. Even though I said it's been going since 2020, this assessment has grown and evolved as it should. The more and more perspectives that we've brought to the table to help test it and plan with us and add to it. And I'm excited to be engaging patient family advisory councils in this work more meaningfully moving forward. I'll be in Toronto next week with the PFAC there. We've worked with one in Pennsylvania before as well. And so I'm excited for this group to get some eyes on this and to provide any feedback and know that this is a tool that we're hoping we can continue to refine over the next couple of years through the Commonwealth Fund, and to make this something that would be publicly available to everybody moving forward in perpetuity. So going to talk about this a little bit. And so these are the 4 Genesis organizations at the bottom right here: Rush, University of Chicago, IHA, and the Commonwealth Fund. And this assessment that I'll tee up, like I said, we started testing this in 2020 in Illinois through the state association. And since we've gotten about 300 organizations this year alone who've engaged in the tool since we launched it in January. And we're excited to have 2 more years of funding from Commonwealth Fund to make sure that this assessment and the analytics and the programming and the playbooks and all that good stuff are publicly available. So everything that I'll talk about, know that this stuff is stuff you could start engaging with as soon as today or tomorrow, or some of our programming that's going to go into next year. And would love to chat with anyone who might have interest in aligning with us. So a lot of words on this one. Big slide, but the take home here that's kind of cool. It starts with our burning platform on the left. And this work really started with Mayor Lightfoot in Chicago and with a phone call. So Dr. David Ansel is one of our primary investigators of this work through Commonwealth. And he received a call from Mayor Lightfoot. This was back in April of 2020. And she said, you know, Dr. Ansel, there's going to be an article that's going to drop in the Trib coming up, I think the next day. And it's going to show that 77 of the first 100 deaths in Chicago from COVID were Black and brown folks on the south side of our city. And she said, this is not anything that's going to be surprising to you or to me, but this is our time to start looking at healthcare disparities and inequities in a more meaningful way, and using COVID as the light to shine on this problem that we know has existed not just in our city, but across our state for decades. And so Mayor Lightfoot challenged Dr. Ansel and many other groups in Chicago to create a racial equity rapid response team and to treat racial inequities in care and outcomes just like we would a code red in the hospital. And so this group was formed in the spring, and at about the same time on the association side, we were putting together what we call the Committee on Health Disparities. I was privileged to be able to co-chair that work. And this is kind of where the stars aligned in the spring and summer of 2020. As we all know, the murder of George Floyd was a huge incident, not just within the United States and our healthcare system, but across the globe. And that, along with the social unrest of that summer of 2020, gave us a burning platform at the association to say, we haven't been doing enough and we need to do more, and we need to align with some partners, and we need to help our healthcare organizations, because frankly, the message we kept hearing was, we want to do something on this front. We will sign pledges. We will put forth statements that racism is a public health crisis. We will do everything that we can, but we don't know where to start organizationally from a process perspective. There's no silver bullet. Like, how can we assess our organization and in a more measured, scientific as a way as possible, figure out where we're doing good and where we have areas for opportunity. And so it was that kind of convergence that really got our teams together at IHA and Rush at the University of Chicago and some civic partners in the city of Chicago to say, let's create an organizational assessment for healthcare organizations that isn't myopic to hospitals, but that could be taken at a community level. And let's create that assessment so organizations can get a sense of where they're strong and where maybe they have room for improvement in a process perspective across some buckets. And so that's what we started in 2020, and we started piloting it, and then got to this point just last year where Commonwealth Fund said, hey, this looks so awesome what you guys have been doing. Let's see how this spreads and scales outside of the state of Illinois. And that's what brings us to kind of where we're at today with our national piloting. Now, when all this work started back in the spring and summer of 2020, these were the 5 foundational components that we held true to, and that we said, regardless of where this goes, we want these things to be components of this assessment kind of forevermore. So one was that we weren't going to compromise on it centering on racial equity, and really asking tough questions to healthcare organizations about their own history, their own demographics, and how they maybe are or are not providing as equitable care as possible to all the members of their community that they serve. We wanted it to focus on some high impact metrics. So we didn't want like analysis paralysis and some huge assessment that was almost too big to wrap your arms around, or that boiled the ocean, if you will. So we wanted it to be that tangible self-assessment that helped promote organizational growth and move organizations to action. So we didn't want this to feel like a leapfrog report or a hospital report card act or some of these things that come out which publicly grade organizations A through F, and frankly just start like a media frenzy over a bunch of data that all the hospitals argue about anyways. And so we didn't want that. We wanted this to be a real like quality. We all came from quality improvement backgrounds. And so it was like, let's make this a true self-assessment and tell organizations the first time you take it, you're setting your baseline and you're getting a sense of where you're at and where you could move towards. And then we'd encourage them to take it annually to fill in those process gaps. All of this while saying it was spurring, and this is what we've seen, which has been really cool, is the collaboration that it has spurred within organizations to have some tough conversations on these topics internally, but then to look outside the 4 walls of their organization, to work with community members, to work with patient advisory groups and councils, and to get a better sense of what it really means to provide equitable care to their community by making them a part of that process. So those are kind of the foundational components of the assessment. For those of you that are with hospitals or healthcare systems, you're all too familiar at this point about the standards that CMS has put forth, some of the alignment that Joint Commission has put out their standards this year. We have been lucky in that our principal investigators, Dr. Ansel and Brenda Battle from the University of Chicago, are very wired in to Joint Commission, to CMS communities. And as these standards were coming out, we ensured that our assessment was going to align with those. So this dovetails really nicely for those healthcare organizations who are looking at these organizations and having their leaders saying, hey, are we checking some of these boxes, and are we doing these things process-wise? And so this has been a nice carrot to get organizations to engage in this. The assessment itself is broken up into 4 buckets: our people, our patients, our organization, and our community. And you can kind of look at this from a DEI lens. Our people and our organization buckets are more internally focusing, where we're challenging the healthcare organizations to look at their policies, their processes, their PFACs or lack thereof, and to say, are we delivering internally? Are we kind of functioning at as equitable of level as possible? And then our patients and our community buckets are looking outside of the walls of the hospital. looking at things like access, our quality improvement processes, looking at data stratification. Are we really assessing our health outcomes by demographics? And how are we working with community partners? And where could we be stronger in those areas? So the assessment is a blend of internal DEI challenge or focus, as well as the health and racial equity focus to those folks that we're serving. The assessment itself is just over 30 multiple choice questions, 34 multiple choice questions. It started at 200, we got it down to 60, and now it's into a more compact 30 or so questions with some sub questions. And so something that usually takes organizations a few weeks to fill out and a couple meetings together. If your organization does take advantage of this, you'll get a nice set of analytics back that we've created, which will give you kind of benchmarking for all the other organizations across the world who filled it out. I mentioned we've got some Canada hospitals engaging, South America is engaged. We're talking to the NHS health system over in the UK, and it's been fascinating talking to these folks in different countries about health and racial equity, and it actually has given me a little bit of hope in that our system, I think across the states, is a little bit more forward and pushing the bar in some of these areas. And so it's been interesting to see how folks across the globe that we're working with are taking to this assessment. But the one piece I'll mention here, which is really kind of cool, and it's been more provocative, was this first report on the left. And I know it's just bar charts, you can't read it, and that's okay. I've got mock reports you can look at and that are on the website for view. But the thing that we did with any organization who takes this is we challenge them to plot the demographic dots of their teams and of their patients who they serve. So we asked them to put the demographics of their board, their senior leadership team, their patient-facing staff, and then their patients, and just to see what that looks like. And we frankly have had health systems, and this started in 2020 with a safety net organization in the Chicagoland area who called and said, we don't need to be a part of a learning collaborative or any other work. We just needed to see this first page of this report because we're seeing that we're serving 60 to 70% Black and brown folks, and our board is 90% white, and our senior leadership team is 90% white, and that needs to change. And we have heard that a lot from organizations. Board diversity has been a big focus of the work that we've done just in challenging organizations to see what those demographic dots look like. So that's a piece of the analytics, but then the other pages dive more into access, quality improvement practices, data collection, community partnerships, kind of so forth and so on. And again, happy to get you some mock reports of what those analytics look like. Now, the last piece that I'll touch on here before we get to hopefully some more fun stuff is the programming side of things. So it was one thing to create a really nice assessment with sharp analytics that would help organizations be a compass to move to action, but we also want to be really mindful of putting forth some programming so that after organizations took this assessment, they would have a playbook or programming that helped them move from a data on an assessment sheet to action. And so we have a playbook that's kind of free for download that walks you through these different human-centered design canvases that we use within our work, which are really just simple structures to hold complex conversations. And we've sequenced them in a way in that organizations can take their data and then do some meaningful strategy planning in the racial equity
72
space.
people on this.
Moving towards, yeah, it's a lot. 72 is solid for Friday. But here is the process with our programming. We're helping these organizations kind of reflect upon their data, pick a focus area that they have energy around and resources to move on, and then put together a prescriptive action plan and a commitment form. So we call these racial equity charters. I know in Illinois, our Genesis state, there's been over 200 of those charters that have been collected from organizations kind of committing to the action that they're going to take with their patients and with their clinical teams to make care more equitable. And so it's been a really inspiring process the last couple of years to walk teams through these learning collaboratives. And the way that we work in person, using our human-centered design approaches and our visual tools, is the old school way, with big canvases and Post-it notes and giving everybody the power of the pen. And one thing that we were challenged with, obviously, during COVID, as everyone was the lack of ability to have rooms like this, to hold real conversations like this. And so we've translated a lot of these visual canvases that we've used and a lot of the process throughout this engagement into a virtual space, which I'll show you in just a minute, in which we can all kind of play around in. But this is the way that we work with folks as we move from assessment to action. So I'm just finishing these remarks up, and I'll pause for a little bit of comment. But this website here, equity.dotankdo.com, I'll put it in the chat. It's we'll give you full access to our digital hub, which has the assessment, all the background that I just talked about, analytics, the playbook for download, and all of this is free thanks to the Commonwealth Fund and to kind of that commitment to this being a public-facing quality improvement tool in the equity space. And so within the digital hub, we've got a podcast series and some different visual tools and things that you all could access at no cost. So I want to stop there as I kind of transition over to the second half and see if there's any thoughts or comments from the group at this point in time. And I can take a look at the chat. Awesome. Okay, so I don't see anything.
I haven't seen any questions come in from the chat. Does anybody have any questions so far? And say, if not, Adam, if you want to go to the next step, and there might be some that come through that way.
Let's do it. Yeah, because that was a lot of one-way street. So I'm hoping at this next turn of the corner, we can get some discussion going. So I mentioned human-centered design and visual canvases and kind of our approach, what we're doing in the equity space. And I'm going to share with you now, and I'll go ahead and I'll keep sharing my screen here for the next several minutes as we venture into this next piece of the discussion. But I've created a mural canvas here, and I don't know how many folks have used Mural before. If you haven't, feel free to go ahead and click in the chat. You can click on this link. What's really cool about this space is that it's open. The link that I'm sharing with you now is going to live on well beyond today, so I'd encourage you to utilize this within your own teams. But I want to highlight a couple of canvases because we're hoping to engage you all in some discussion, and that I can upskill you or teach you about a couple different visual canvases, like what does human-centered design mean? And so both of these canvases that you see here, and I'll go ahead and zoom in. If you haven't used Mural, again, on the bottom right-hand side, you're going to have a little hand that'll allow you to move anywhere in the mural. And if you click on that hand again, you can click on any Post-it note and type anything you would like into those Post-its. And so I showed that picture of all the folks around the table with the canvas, and it's very obviously like easy to do this in person because we can throw everybody Post-its and a marker and we can jot their thoughts down. But with Mural, we can do the same thing in virtual rooms like this. And so what I was hoping to do today was to get some opinions from this group on a couple canvases, and I'll tee up the first one. And as you can see, we've got kind of 4 personas that we thought might come to the room today. The lane on the left here being patients and family members, the lane in the middle being executives or folks from associations that might be on the call, this third lane being clinicians, and then the last one being researchers. Now, we may not have captured every demographic on the line in those 4 buckets today, and that's fine. What I encourage you to do is, whichever one of these you gravitate towards most, go ahead and type your thoughts in there. But what we'd really like to do is to see some engagement in these visual canvases. So this first one is the persona canvas. And the question that we'll pose to everybody in the room is, where do you stand as it pertains to health and racial equity? So as a clinician, what are some of your needs? What are some of the positive trends you see in the environment or within your healthcare organization? Where do you see opportunity? Where do you see headaches? What are some of those things holding you back? Where are the negative trends? What are your fears in this area? What are your hopes? And as you can see, these canvases, like I mentioned before, they're simple structures to hold complex conversations. And so when we use these the most with patient family advisory councils or other advisory advocacy groups, because you can take this persona canvas and you can wrap any question around it. For example, you could have a PFAC and you could tackle something as operational as throughput, or medical assisted treatment and OUD. You can take these canvases and apply them to any topic that you would like to. And they're really effective tools to print off. We always print them in big, large form, put them in the middle of the table, and you can facilitate quite the discussion over 20 or 30 minutes. And as I said, I'll give Naomi and Lindsay our links where we've got some videos that teach you how to facilitate these canvases, and they're all free for access. But I wanted to give you all a chance to engage in this and tell us a little bit about us at PFCC, kind of where your heads go when you think of health and racial equity within the healthcare space, in that persona that you have, whether you're a clinician, whether you are an association or a researcher or a patient or a family member. And I really, really appreciate folks just diving in, especially to the patient and family bucket here. We've got a lot of kind of activity going. Check the chat here.
Adam, I'm just going to mention for those, once you click
Yeah.
on the link that Adam dropped, you join as a guest. You don't have to sign up for anything. Just join
Yeah.
as a guest. And if there is anyone that might be having any tech issues, or it may just be a lot, just drop your answer into the chat and what persona that you fit under. And then Adam, one thing did come into the chat, and I don't, what was said was technically I could fit into each of these canvases.
Right. So I would say, just for the purposes of today, I really want to just expose folks to a new tool and garner some discussion. So pick whichever lane you resonate with the most right now, or whichever persona you feel the most strongly about interjecting into the conversation, and go ahead and type that stuff in. And as Naomi said, yes, we definitely come in as a visitor. The beauty of these mural canvases too, and we use them like this, is that anonymity. And we do a lot of what we call listening sessions or focus grouping, where folks can come in and type in whatever they want. And as you can see, you get a really funky, animal. We've got a lobster and a ladybug and a koala. So feel free to type in your names if you'd like, but this is all anonymous. So whatever you type in, we can't track to any one in particular individual. So these are really good when you want feedback from groups that you feel like might not be as easily candid if they were in an in-person group setting. And I think I see another question about the color logic. And so this is one, we just try and keep the colors, to those sections. So we have a sense of, oh, all of the spheres are in red, all of our headaches were in pink, all of our hopes were in blue. And so as we facilitate these, it's just an easier way to kind of map where stuff goes. Because as you guys can see, it gets a little chaotic in here when you have 50 or 100 people at once going to post-it notes and trying to type stuff in spaces. But that's the only thing behind the color logic. Yes. Okay, Emily, yeah. So I'm just going to zoom in on some of the comments here. Building trust, not enough clinicians and nurses.
So Adam, can you clarify one more time? When somebody
Yeah.
goes in here, does it matter what color they pick when they go to type in?
It doesn't. If you're gonna blend the colors, so long as you can keep it right around that area, right? Like you've got positive trends, opportunities, hopes, fears. So if you're typing something in that's a headache, maybe just keeping it over in that general vicinity, and not putting your headache over in the hopes column. So no worries though, if you're just picking random post-its, and don't worry about the color logic. This is just, I know this is probably totally brand new territory for almost 100% of the folks on the line. So really just trying to expose you to a new tool. I'll say too, as well, as if you're in a position where you want to facilitate conversations like this, a mural is free as well. So you can sign up and make a mural account, and you could download any of these canvases and do exactly what we're doing today, with no cost to anybody. So wanted to make that clear. check the chat. Yeah, so Susan, don't worry about the colors.
Do we have any researchers that are on? Just looking at it, at that persona. I'm not sure if there's anything in there or not. I know sometimes we have researchers that join us. So I don't know if anybody is here today. Susan, I see your comment. Can I ask you to expound on your question? How can I help the cause and be a good ally? Are you asking that question or are you putting that in? Can you give a little more, I'm sorry, just a little more context to that? Perfect. Got it. That's your sticky note comment. Okay.
Awesome.
So your persona is a clinician and your question is how can I, or putting it on that persona, how can I help the cause and be a good ally? Thank you. Yeah, we know this is something new. It's something different. So we're keeping an open mind as we work through this.
And I've got a thought there, and this is just, Susan, one thought, and this is something that we're doing with another hospital association on the West Coast. But for example, we're doing some maternal morbidity mortality work with them. And they brought us in to help think through programming and how we could approach certain issues at a regional level within this state. And the first thing that we really pushed them on was what you can do to be a better ally is allow us first before we jump to strategy or planning or thinking about resources or partners is let us talk to Black and brown mothers in this area and get a sense of how they feel and of how the process, the birthing process was for them and what they think we should do around access or what those real pain points were. And so my biggest answer to that question you chatted in is empathy. And using tools like this or a mindset or an approach like this to before we jump to action within a quality committee or a DEI committee, we take the time to do a little problem exploration and definition with the folks who are actually impacted that we're trying to bring about change for. And so I think if there's one message we could put across today in all of this, it would be that. Think about the patients in a real way that is garnering feedback from them that you could integrate into a process that would be more value added. And I think that's one thing as a challenge for all of us in the healthcare system that we can always do better in is listening and canvassing and being really meaningful about that before we worry about our own internal strategic plans or metrics or how we're going to drive change. Engage in the local community, great.
So Adam, are you able to take us through just a little bit based off of the responses that have been dropped through the different personas? How, like, what happens next? How do you integrate that, the response?
Yeah, so I'll get into that with my next canvas. And usually what we'll do with teams is we'll do a series of canvases over a half day or a day session. And like I said earlier, these are all simple structures to hold complex conversations. And any one of them can be very valuable as an insight gatherer. But depending on what your aim is, kind of cycling a few of these canvases together will tell you a more operational story. And so before I kind of dive into real-time analysis on any of these, because that's always awesome to do. But the thing that is really cool here is that we've got, a few distinct personas here. We might not have a lot of researchers on the line, but what we've done in rooms before where we've had patient advocates and clinicians is we break the rooms up and we say, y'all tell us what you think from your personas and where your heads are at. And then having that cross exchange then of the patients walking over and see what the clinicians think and the clinicians walking over to the other persona campus and seeing what the patients and families are saying. there you get an opportunity to try and identify where there's synergies or where there's bigger gaps, right? So, you know, the synergy here, and this is very high level, the patient and family group has community groups as an opportunity. And we've got a hope here with the executives of the associations of engaging the local community. And so one thing that you can do, like maybe the easiest thing is just that. If you have a couple different groups, having them doing their own exploration and persona mapping, and then visually identifying where those synergies are, putting them in the middle, and then saying, where do we have the energy to start? Where can we get some work done? So that's one kind of connectivity here, as you have different personas. And the next thing, Naomi, that I would say, and this is an easy sequence, like honestly, these two canvases though, ideally I would do both of these in a 90-minute session. So we would take 25 to 30 minutes just to focus on one canvas, get thoughts out there, have people talking a little bit. And then the second canvas I would go to could be a design criteria. And this one is more operational. So with the design criteria, if you float your cursor down, please keep engaging in those top ones if you'd like, but I would invite you to listen here to the tee up here and to start chucking some thoughts down below. So after you have some time to do meaningfully exploring a persona and having discussion around that, the next kind of natural step, if you're in a kind of a programming mindset, is what are those things that we should be doing differently, or what are those things we should stop doing? And so we use this canvas, and it's a super simple one. Again, you can apply this to any project that you're doing or anything outside of PFACs or equity, but it's a 4-action framework called the Design Criteria Canvas, and it asks 4 questions. What are things we must do? What are some of those things we should be doing more of, or we could be doing more of? And what are those things we don't want to continue doing? What are those things that aren't value added? And so a lot of times with teams, as we're early in project planning or in development mode, we'll use this as like our scope identifiers to say, what do we have? And I always say with this one, using the top 2 rows first. Use those as your guardrails. Like out of the gate, what are the steps that we should be taking that we know we're not doing right now? The musts. Starting there is easy. And it's also easy for us as humans to go to those places and say, oh, this isn't working and we need to stop doing this. So start with the musts and the won'ts. Like, what are those activities that we feel as a persona, as a patient or a family member, as a clinician, as an association, must we start doing moving forward to enhance equity? What are some of those things we need to stop doing that aren't working? And then the middle lanes here of should and could, that's where you can dream a little bit. And it's very often we'll have Post-its that are in between those lines. And that's where these canvases are all platforms for discussion, right? They're not fill in the blanks. They're not ad libs to try and get to a strategic test. Every Post-it note that you put in here is a data point, and it's a talking point. So someone just typed in, assess the current practices. It's a great discussion point to say, oh, what practices are we talking about? So each of these is just really tools to like elicit some deeper conversation and thought in any of these areas. And so we've got our little kind of directions under these 2 of what these 2 canvases are, but feel free to start engaging in that bottom row if you'd like to, but you guys are really doing great on the top. I wish we had like a half a day, because I know we only have a few minutes left, but
Adam,
this is great.
One of the questions that came in, and so when talking about PFACs, one of the questions is, do we assume everyone has a computer at a PFAC meeting?
Yes, no, we shouldn't. And so this is one too where we've done hybrids before. The slide deck that I showed you with the folks in the room, that was a hybrid meeting in that we had about 12 folks in person who had the canvassing work that we're doing. And then we had a whole huge screen with folks that weren't there that were doing the same canvases through Zoom. I think on the PFAC perspective, it's so bespoke and case by case, right? If you are still doing PFACing virtually, I think that it would be important to have some tech. You can do this from your phone, but it's not ideal. The ideal state with any of these canvases is to get folks sitting around a table, elbow to elbow, writing down their thoughts, putting the Post-it notes on there and sharing. But there is a level of tech here from an accessibility perspective that is important. You can do it on your smartphone, but it's kind of tough to zoom in and type in the Post-its, but it is possible. It's a great question.
Emily, do you mind coming in and speaking to what you just dropped into the chat? What was mentioned is this is one reason why we have a facilitator that records people's reactions in our listening session, because there is a wide range of devices people have access to as they participate in the video session.
Yes, and it all depends on exactly what the listening session is about, what the slides look like. We do journey mapping, we do specific questions, and what are people's thoughts. Sometimes we show something visually and ask people to respond to it. But we have so many people, especially from marginalized communities, who all they can do is get on a phone. And it just feels like it's too much to ask them to be typing in. Whereas we're really trying to be thoughtful about making sure everybody gets to participate, to ask you, what's your thought? What are your thoughts? We teach them how to type things into the chat if they come up with another thought after they, gave their original one. Anyway, that's the real reason. It's because we feel like it's more equitable.
It absolutely is. And Emily, thank you for speaking up, because that just gave me the light bulb. And I'm going to show you a different mural that shows how we solve for that. So we hold a lot of these, we call them listening sessions. And it's really simple what you just noted. You have somebody on the line who's not me, like say I'm facilitating the conversation. You have another team member and their sole responsibility is scribing. So as folks talk, you're the stenographer, you're the court reporter. This is a big session we just did, and half of these folks were not on computers. But the level of detail that we were able to capture on some of these questions by just having them talk on a phone, and we had somebody who was typing their thoughts out and putting them under the correct areas. So there is an equitable way to utilize a mural tool like this, even if folks don't have access to a computer to type into. And more often than not, folks, even if they do have a computer, they like just talking and having us sit back and type. So that would be, and I was remiss to not even teeing that up at the beginning, but this was a huge session we did that was 90 minutes with about 30 folks. And again, about half of them were on computers, the other half were just on a cell phone. And so we were just there kind of typing and chatting out what they said. So that would be one way to operationalize this if there is that tech barrier.
Emily, that's a great point that you bring up. She mentioned in the chat, and we ask if we have recorded their thoughts accurately.
Yep.
Harb, I see your question in here. Where is the equity with tech knowledge?
Technology.
Is there anything
Yeah.
else that you would like to add to that, or just one?
What I just teed up to Emily is what I would kind of stick to. So we've been saying, like at the beginning, setting those barriers, up in the boundaries and saying, it's totally fine. If you don't have a computer, if you don't want to type, just speak freely and we're going to record your thoughts and they're going to be shared with you right on the screen. So let's say, as I'm typing Emily's thoughts here, like give me the thumbs up if I captured from a teach back perspective what you were kind of voicing. And so that's at least how we've kind of approached that tech barrier before. The other beauty of these murals is that they live asynchronously. So someone could engage in the conversation, and if they wanted to come back the next morning or the next night and add their thoughts or check the boards, you can do that. So it's not like these sessions have a start and an end point. And that's always important when we do listening sessions. You know how crazy schedules are, and there may be some critical opinions you want to have, but they can't make it during the 90 minutes when we're talking. but they can still have access to the mural. They can look at what everybody else said in the meeting, and they can come back and kind of add their thoughts or their hearts or their thumbs up. And so that's kind of a nice piece of this approach too. And Harv, you got your hand raised.
Yeah, to follow up on the technology, many people with or without inequities have tech issues as we all live through Zoom and whatever, and might be intimidated as far as speaking up. You said you showed the room with people around the table, elbow to elbow. I would think that only those, because being involved with PFAC many years ago for 3 years, there were those that wanted to dominate the meeting, and there were those, with their speech and or their stickies, and there are those who are willing to listen. Any comments about the elbow to elbow meetings, and that in the 45-minute session, maybe 1 or 2 people didn't even have a chance to speak, period?
Yeah, that's the beauty of this approach. Is that everybody elbow to elbow, the first thing we say, you sit down and there's a Post-it note in front of you and there's a pen in front of you. And everybody's got the power of the pen. And depending on, to your point, Harv, it's different with every group. And you have to have a little knowledge of that group. And if I know that coming in, that maybe we've got a couple loud voices and folks defer to them, how we approach a lot of this stuff, then the tactic is solo ideation. So we'll say, okay, guys, we're going to work through this persona canvas over the course of the next 45 minutes. And we're starting in the middle with what y'all need. Everybody take 2 or 3 minutes, write down a Post-it or 2, what you need, what's meaningful to you. And so it's not a discussion point, and you can play some music, you can be talking in the background, have everybody write that down, put them in the middle. So you can take these canvases and approach them facilitation-wise very differently. And if we have groups where we know there are dynamics because of leaders in the room or loud voices in the room, we'll do a lot more solo ideation tactics that then quilt together everybody's thoughts. And over the course of that time, you're getting a true representation of what folks said who might not be comfortable even jumping in and writing shoulder to shoulder with folks. So that's one way that we've used that before. And we know we've got voices in the room that want to be heard and need to be heard, but that might be quelled by the social dynamics of the folks around the table. That's one thought.
So Adam,
again, yeah. Go ahead, Naomi. Sorry.
One question that we received before was, as you're speaking about that, thinking about what strategies can health plans use to improve health equity data collection?
That's a big one. So we kind of have tackled 4 areas. We've tackled the real data, the SOGI data, the SDOH data, and then health outcomes, stratified by demographics. Those are kind of the 4 data elements that we're looking at. The first thing that I think came up the most, and we're doing an affinity group on this exact topic next year, but it's the proper training and education of folks on our front lines to collect real SOGI and SDOH data. I think that is something that is too often overlooked, and you might have health systems or organizations saying that they're collecting all this data process-wise and oh yeah, we have that in place, but they may never have, or they may not have to the right degree train their folks up on the difficulty of collecting that data. They also are often not auditing it. So I would say the biggest opportunities we've seen from a data collection perspective when it comes to real SOGI or SDOH data have been in a focus on helping train the workers who are collecting that data, and then auditing that data in a proper format to ensure as much as possible its validity and the standardized fashion in which they're collecting it and then analyzing it. Those are probably the two biggest opportunities in the data space that I've seen. And we have a whole series of canvases for the folks in that space, for the frontline workers who are collecting that data, to cycle them through a process like this and say, what's working, what's hard about collecting this data, what questions don't you understand, where are there process gaps. So that's where kind of my head goes to that question, Naomi. Probably not a perfect answer though.
Well, we know there's no perfect, only
There's no
progress,
perfect.
right?
It's a Friday afternoon answer. It's yes.
Another question that just came in was about multi-language data.
Yes, that is an amazing question. So we have two bilingual individuals at our team, and we've had to facilitate sessions in Spanish before. And usually the groups we're working with, the bilingual nature of an approach like this is not an issue, but I completely hear and validate that especially from if I'm thinking of a PFAC perspective. And so I think it's critical that you have a facilitator or whoever is teeing up this exercise, that individual or individuals have a handle on the language and on the cultural aspects of the folks who may be around the table. Because if English is not your first language, and especially if that's trouble from an oration perspective, probably even more of a difficulty writing things down, that is critical. And that's a fantastic question to flag, because this would be the last thing you want to do with this approach, because it's meant to be so empathetic and gathering thought, is to by design alienate someone because there isn't a comfort level of engaging with that process. So it's a fantastic point, and one that I think you'd have to think about before you even put this approach in front of a PFAC or a team, ensuring that you would solve for all the language and cultural kind of appropriateness that you would need to do this in a truly an equitable way, so that each of the learners feels like they're in the same spot to be able to engage with the conversation. Great question.
Thank you for that. If anyone has additional questions, please raise your hand, or you can come off mute, or you can drop it in the chat. And I will ask Lindsay and Laura to help me keep an eye, because we have so many.
Yeah.
Just make sure I don't miss anyone's hand. One other question that came in is, how is equal opportunity for healthcare promoted?
See, I'm trying to find that question, Naomi, because I'm trying to wrap my head around the.
Oh, sorry. It was one that came in with registrations, and so I don't have any additional context
Okay.
to give to that.
Yeah, I think my only thoughts there would kind of dovetail with the last question that Harv asked. That was really good, in that not just from a language perspective, but from a disability perspective, from every perspective, before you put out a visual canvas like this or take an approach like this, whether it be in person or virtual, is to do that canvassing of the group itself that you want to gather the feedback from, and ensure that you are setting the conditions as best you can to have it be an equitable conversation and meaningful dialogue for everyone, that they can all engage with a level of comfort that you feel good about coming in. And with all that said, unfortunately, I did not do that proper canvassing with this group. So I am completely, open and being honest with that, and knowing that there's probably a level of canvassing that we should have done from a tech perspective and maybe a discovery perspective to ensure that this group was even going to be comfortable with this engagement. So I'm remiss in not taking my own advice with my response to that question, but definitely as you're facilitating this in a meaningful way, in a more formal way, that canvassing up front is critical.
Thank you for that, Adam. And, you know, just for the authenticity and the transparency. And that's one of the things that we pride ourselves, if you will, with our community of practices. Nothing is perfect, but we show up authentically and transparently. And there are always opportunities to learn, just as we've done here with this today, right? And so one of the things, if you wouldn't mind just connecting the dots from the very beginning when you started and you showed the presentation, if an organization wanted to come and just see where are they as far as their
Yes. So let
okay,
me
you know
do
what I'm
that.
talking.
Yeah, and I'll stop sharing my screen. And again, that mural link is yours. Feel free to engage in it. But yeah, the racial equity work that I teed up, I just put the website in the chat. Again, you can access that free publicly. And if your organization wants to do that self-assessment, you may, and we can get you your data analytics and then the programming, like our playbooks and the stuff that we're doing moving forward. They're going to be using visual canvases just like you experienced there. And the last thing I think I would say is don't hesitate. Anybody on the line, if you want to utilize these tools or are thinking about doing them, I'm happy to jump on the phone and kind of talk through how you might operationalize that, whether it be at an in-person session or virtually. We love kind of socializing these visual canvases and the work we're doing as much as we can. So don't be afraid to reach out if you do have questions or have any interest in trying to do this stuff at your own meetings. And I'll go ahead and drop the last thing in the chat. That's our website that has a lot of these tools. We have a whole gallery that we're making free to the industry. So you saw 2 of them today, and there's about 10 or 12 more on there that, depending on what you're trying to achieve, could be useful tools for discussion. Hey, Libby, thank you for having me.
Thank you so much, Adam. Thank you, everyone, for spending an hour with us on the last Friday of October. Just want to remind everyone, you'll be able to find the recording on our YouTube channel next week. If you haven't already subscribed to our channel, please do. We're on Instagram. You can always connect with us there, as well as you can stay up to date with what's happening, where we're going to be. You can come, if anybody's going to be in Boston next week at the Putting on the Care Conference, come and see Lindsay and I. We'll be in Boston next week. If there are no other questions, comments, or concerns, wishing you all a happy and safe weekend. Take care.
Thanks, everyone.
Thank you.
Thank you, Adam.